Welcome to Behind the Sports Medicine Podcast, the podcast that pulls back the curtain on the evolving world of sports science. I'm Andrew Rizza, an athlete trainer with decades of experience in professional, collegiate, and high school sports.
And I'm Cameron Roth, an orthopedic surgeon and a consultant for the Chicago White Sox.
In each episode, we'll explore the real-world challenges and opportunities facing today's human performance professionals.
Our hands-on experience is transforming sports medicine and breaking barriers through innovation and teamwork.
Hey, everybody. Welcome to this week's Behind the Sports Medicine Podcast. Today, we have Eric Schoenberg, who is the owner of Diamond Physical Therapy, which is located at Cressy Performance in Florida. He is a board-certified physical therapist, strength and conditioning coach, and specializes in the management and rehabilitation of baseball players. Eric, welcome to the show.
Thanks, guys. Happy to be here.
You're an expert working with baseball players. What makes the baseball athlete unique from a rehab standpoint?
I think a lot of things. So I think the first thing I would say is probably just their anatomical variance is kind of a big one. So I think there's unique adaptations that happen when we throw at a young age that needs to be appreciated when rehabbing an athlete. So I think there's certain things that some people would view as abnormal that I think are completely normal depending on, the athlete's presentation. So that's one. Certainly just understanding the unique demands of throwing and in the swing, just understanding just the sequencing and kind of what the body needs to be able to do, which is different. Obviously, there's other rotational sports, there's other overhead sports, but baseball has some unique components that need to be, paid attention to. So I would say that's a big piece of it. And then just understanding the unique characteristics that make somebody good. So I think sometimes we view something as, well, maybe this doesn't look right, or maybe this doesn't match up with, another athlete. So therefore we have to change it. And I think that's something that we need to be really careful about, is just not coaching the uniqueness out of somebody, because that's usually what makes them great. That's usually what got them to where they are. So I think just because we haven't seen it before, or just because it doesn't fit a particular profile, that's one thing that, we've learned some lessons on, is just not trying to fit people into a box. What makes them unique is usually what makes them great. And we just have to keep them strong and pain-free in those kind of unique positions that they get into. So changing them, you might make them pain-free, but you also might make them worse baseball players. So I think we got to be careful with that.
Can you expand upon that? I think that's a really interesting point, because to make it to the highest level of Major League Baseball, you obviously have to be incredibly talented and unique. What are some examples of that uniqueness, and how do you balance that, maintaining the uniqueness versus being a completely pain-free athlete?
Sure. So, I think that's one of the big lessons I learned when I started going down to Cressy's and open up the practice in Florida. Is one of their co-owners at the time, his name is Brian Kaplan, who's now the pitching coach for the Arizona Diamondbacks. And he pulled me in the office and he said, we brought you down here for a reason, but there's one thing that you can't do, and you can't just come in and change what makes people great. And it really stuck with me. So I asked him exactly what you're asking me, what did you mean by that? And I think you could look at something from a young age as something as simple as where a kid releases the baseball. So just, whether they're throwing the ball, from, a straight over the top position, or whether they're a 3/4 position, that's just probably the most simple example is, you get a dad or a young coach who says, you shouldn't throw it like that, you should throw it like this. And all of a sudden their motor preference isn't to do it like that. So therefore we're putting them into positions that don't naturally occur. And then we create a high volume of activity in a position that is, I guess, unnatural for that particular athlete. So, that's at the lower level. At the upper level, it might be somebody landing closed. It might be somebody that, has a front leg that isn't, the typical stiff front leg, that has a little bit of flex in it, that we know isn't necessarily ideal, but they're pitching in the big leagues at an all-star level. It's really, really tough to go in there and make that change right away. So you have to, I think the biggest thing, in terms of addressing that or navigating that, is just to talk to the athlete and be able to say, what are the reasons why you think you got hurt? And, what are the things that you want to change? Because sometimes they have this window now of time, unfortunately, where they're not playing the game, where they say, man, I've always wanted to change this, but I never felt like I could because I never had the time. So this is something that we want to address during this long rehab. But it takes a lot of trust. It takes a lot of buy-in from the athlete. So, I guess just maybe a delivery thing or a mechanical thing where we as PTs might know a lot about that, but that's not necessarily our wheelhouse. So, I think that's where, working as a team and trying to get everybody collectively on the same page with what they want to do and let the athlete drive, the conversation. I think that's usually the way that we tend to address it.
You build recovery plans, rehab protocols, return to sport timelines, because you know outcomes don't happen by accident. Your financial life deserves the same intention. Bode is a fee-only fiduciary firm that starts with a plan. Your goals planning statement, a personalized roadmap that keeps your money aligned with where you're actually headed. Built around your life, backed by conviction. See what real planning looks like at beckbode.com.
Looking to get back in the game and feel your absolute best? Boston Orthopedics and Wellness has you covered. At Boston Orthopedics and Wellness, they're all about helping you recover faster, re-energize your body, and truly revitalize your health. Whether you're dealing with an injury, looking for cutting-edge recovery therapies, or exploring innovative treatments for orthopedic conditions, their expert team is ready to guide you every step of the way. From advanced regenerative treatments like PRP, stem cell therapy, and peptides, to performance and wellness services like NAD+ therapy, men's health optimization, and weight management programs, they offer a comprehensive, personalized approach to getting you back to peak performance. This isn't just treatment. It's a path to moving better, feeling stronger, and living pain-free. Boston Orthopedics and Wellness is where your comeback starts. Mention Behind the Sports Medicine podcast to receive 15% off your first scheduled appointment. Learn more and start your journey today at bostonorthopedicandwellness.com.
What are some of the upper extremity injuries that you're most often seeing in clinic? Is it more rotator cuff pathology? Is it more UCL type injury, the Tommy John injury? What's the prevalence that you're seeing?
For us personally, I mean, I'd say elbow wise, it's UCL, nerve, flexor, and then, bone spurry osteophyte presentation, and then the loose body stuff, which is running rampant in the big leagues right now. See a good deal of that as well. And then in the shoulder, I'd say more labrum than rotator cuff pathology, but we do see both. And then lat, pathology, and then thoracic outlet, I would say would be the biggest ones if we're just looking at the elbow and shoulder. Obviously, there's some wrist stuff and hand stuff and batters and things like that. But I'd say if I had to pick, the top two, it would probably be UCL/flexor, either pre-op or post-op, and then labral, some sort of labral pathology, I'd say would be the highest ones.
And do you think that these throwing injuries are becoming more prevalent in the youth level or youth athletes in general? Is it because they're trying to chase miles per hour, or is it more they're trying to specialize for longer periods of time over the year?
Yeah, I don't know. I mean, I don't think there's a real rise in. I guess there is in a way, but it's been an epidemic for a long time, right? So I don't think it's anything all that new. So I think the struggle from like where we sit is like, I think we know what a lot of it is, right? It's pitching on multiple teams. It's pitching year round without taking breaks. It's not playing multiple sports, early specialization. It's, over aggressive dads and coaches at a young age that prioritize winning over development, right? So there's not one thing. I mean, anybody who says it's like one or two things is kind of just missing the boat. I think it's an epidemic because we tend to focus, I guess, on the wrong things at those early ages. It's not about development and winning. It's more about just showcasing and, trying to get to the next level, which I respect and understand, but I think things have gotten out of sorts a little bit, and the kids are the ones that are suffering for the adults, dream and the adults' pocketbook and so on and so forth. So
we talked to Dr. James Andrews, who's a big advocate of this and works with the MLB and has for many, many years. And he's sort of a leading figure in this.
Absolutely.
What's your role in this? How do you balance rehabbing and getting athletes back to where they want to be versus preventing them from experiencing overuse injury and working with workload management?
I mean, I think for the people that we can get in front of us, unfortunately, by the time they get in front of us, they're, at least in my realm, they're already hurt. So in the gym, we get a lot of healthy athletes who don't have, injury yet. And, our job is education. I mean, we need to be the leaders in education, whether it's, volunteering our time for, youth seminars, or whether it's, an online presence, or, just trying to sort of get the story out and get the word out to as many people. At the youth level, you got a lot of people that are coaching that are just, well-to-do parents that are willing to donate their time, and they don't have the level of education expertise. And that's where a lot of these problems start. So how do you take somebody who works 60 hours a week, and in the goodness of their heart, they're trying to help these kids and provide structure so they can have a team, but they don't have any expertise in that area. And then you get to other levels where you have all the expertise in the world, and it becomes a business, right? Where you're out for yourself. So our role, I think, still is, it's about education. It's about, lending our knowledge to as many people as we possibly can. So, an example for that is I have 2 kids that play college baseball, and realizing that they don't have a lot of support. They have athletic trainers who are doing their best, but they have multiple teams to cover. They have coaches that are doing their best, but it might be their first head coaching job or whatever it may be. So it's just, in those cases, it's like, we do as much as we can to help these kids out and give them knowledge and use our network to get them in front of, whether they need to get seen by somebody like you, Dr. Roth, or whether, they need imaging or whatever it may be. It's just trying to help facilitate stuff before it becomes too far gone and, they're on the operating table.
We had just interviewed an All-American soccer player from, she played at Johns Hopkins, Erica Mulholland, and we talked about youth soccer, really. And it's almost the kind of the same thing that we're dealing with baseball, where these kids are playing specialized soccer or playing another sport. They're playing 2 sports same day.
Yep.
And we asked the question, what is it that you are finding that is causing this kind of epidemic with, and we talked about ACL injuries with these athletes. And she said it was private equity money. And I mean, quite frankly, it seems like that's what's happening with a lot of these sports.
Yes.
If that's the case, how do we turn the clock back? Can we, or are we too far over our skis to be able to do that?
Shoot.
In the same breath, if we can't, what do we do?
Yeah. I mean, I wish we could turn the clock back. I don't know if that ship has gone too far, and unless it comes down to some sort of legislation or something like that, where people just physically are not allowed to do certain things. Like, I'm not really sure how to turn back the clock on that. I sure wish we could. I think it's creating leagues. If you have some financial backing, you create leagues where money isn't the number one objective. And then you kind of bring it back to the days where you're just focused on kids having fun and kids learning the game and falling in love with the game, and then letting them develop, as time goes by, rather than trying to rush development and trying to put the cart before the horse. If we can't turn back the clock, I mean, I think it's just a matter of perhaps, what we do down in the gym is we just tried to create sort of this collaborative effort to try to give people as many access points as they can, whether it's to hitting, whether it's to pitching, rehab, manual therapy, strength conditioning, whatever it may be. So just recognizing that, like, one of the trends, I guess, as an example that we're seeing that's just really helpful is we're seeing kids skip summer ball or go in educated into their college season, saying to the coach, listen, like, if I got to make the team, I've got to make the team and participate in fall ball. Like, I get it. But if I'm a guy, like if I've already earned my spot and I already pitched 70 innings in the spring and I pitched 30 innings in the summer, like, what are we actually getting out of pitching in the fall if you want me healthy for, another 2 seasons in the spring? So I think a lot of it is advocate, patients or athletes advocating for themselves, whether we like it or not. I think the transfer portal has given athletes a little bit more say in what they do, because whether we like it or not, they can leave if they don't like their current circumstance, which part of me hates, but part of me, I think, from answering your particular question, gives them a little bit of authority of how they want to manage their own career, right? Otherwise, we're basically, mercenary is too strong of a word, but we're kids that are going to school. Yep, they're giving us a few bucks to be there. And then we got to do whatever we want. And it ends up, in often cases, it ends up in surgery, right? Or multiple surgeries. And then their career is sort of capped. So I think, again, it's education, it's communication, it's finding the right fit, right? So that you have a coach that you can trust, that knows that, they have your best interest at hand. But I don't solely blame the coaches, because their job is to win or they get fired. So it's tough, man. It's a tough set of circumstances, but to us, it's always education. The more people we can educate about what the current state of the game is and what they can do to advocate for themselves at any level, whether this is talking to players' agents that are in the major leagues, or whether it's talking to, parents and kids that are just embarking on their high school and college journeys.
Let's talk elbow.
Yep.
I want to talk UCL and flexor WOD.
Sure.
In your experience, what are some early warning signs that athletes and parents might miss for UCL or flexor wad pathology in the elbow?
Yeah. So I think clinically it's these like micro losses of range of motion that kind of sneak up on us a little bit. Like, hey, I can't straighten my elbow as much without pain, or I can't touch my shoulder anymore without pain, or I can't rotate my forearm. And then tissue quality. I think those are the two big things clinically that start to creep up on us because we don't always have access to good manual therapy until we get to the major leagues. Like we have dozens and dozens of guys in the minor league side of things that are in college for sure, and then certainly high school. Like there's just not as much. There are some cases where they're really, really great, and there's others where it's not. So that piece I think gets missed. I think kids do pretty good in the weight room now. I think they do pretty good with their warm-ups now. I just think the hands-on stuff is limited. So loss of range, tissue quality. And then from a communication standpoint, I think it's this idea of like pain versus soreness. Like, are you hurt or are you injured or, that sort of thing. It's like, I think those things are a little bit passe, right? I think that's a little old school where that's how people are conversing. And then from a performance standpoint, it's drop in velocity, even if it's a small drop in velocity. Command issues are usually even come before that. It's like kids that are strike throwers all of a sudden are not strike throwers, and their missed patterns are predictable. And then they start to create a narrative that just isn't true. They start to convince themselves that it was the ball or the weather or whatever it may be. So I think it's just honestly assessing how you're doing from a performance standpoint would be useful for an athlete. And then again, these small changes that can occur either in the weight room or, when they're just getting loose to get ready, where their body is slightly adapted in a negative way that they need to pay attention to. I'd say those are the big early warning signs that athletes tend to miss.
Do you see your non-operative or your team's non-operative treatment of UCL injuries that may not benefit from surgical intervention?
Yeah. I think it's definitely a cessation of throwing, but I think the thing that we work really hard to try to encourage is that window of no throw is like a golden ticket for making adjustments on things that need to be adjusted. So we dig really deep on trying to figure out why is there an accumulation of stress in that part of your body? Is it a strength thing? Is it a fatigue or overuse thing? Is it a mechanical thing? Is it a tissue quality thing? Try to identify those things. Is it a lower half issue? So when they're not throwing, it's not just misconstrued as I'm taking a break from everything. In fact, it's the exact opposite of that. I am now building a blueprint for when I am allowed to put the ball back in my hand. Now I'm more prepared to dissipate that stress better so that it doesn't accumulate into that one spot. So I would say 4 to 6 weeks off of throwing, depending on the severity of the injury and when we see them, and then make sure that they meet some objective benchmarks in terms of not just range of motion and pain-free state, but we'll look at things like grip strength, and we'll look at a lot of different isometric activities that we do for the fingers and forearm and wrist to make sure that stuff is in a good spot. And again, it's different for every athlete, but yeah. So for every week they're down, I'd say there's a week of throwing that has to be used to build back up. So as a general rule of thumb, 4 weeks down, 4 weeks up, and then, see where you're at on the bullpen side of things. So in a case like that, what you were describing, I'd say 6 weeks of no throw sounds appropriate. Still, I don't think that timeline really changes all that much for tissue healing. And then 6 weeks of a progressive buildup from a grip activity, increase, and then obviously from a throwing standpoint. So we usually precede the baseball throwing activity with medicine ball work and then plyos, and then we'll go from there, 2-hand plyo, 1-hand plyo, and then we'll progress their throwing where we're closely managing the variables, obviously, of volume, frequency, distance, and intensity, measure velocity of their throws, and make sure that they're not just using feel alone for progression. They're using other metrics to be able to, decide how are they following this high-low model of throw and rest in order to build themselves back up.
In order for them to avoid seeing you or Dr. Roth or an athlete trainer like myself, what role does workload management play?
Here's the challenge, and here's the thing that I'm not 100% sure of, is when we talk about workload management, I think it's a great buzzword, but I think in some cases guys get injured because they're working too much. And in other cases, I think just as much, they get injured because they're working too little. they pitch a lot, but they don't throw enough in a lot of cases. So they haven't built up their tissue capacity to earn the right to get on the mound as frequently as they do and to throw as hard as they frequently do. So, we watch people, go through a major league offseason, and the younger guys are throwing 95 miles an hour in early December. And the guys that have been around forever don't do that until the last time they touch the mound before they leave for spring training, or maybe not even at all, right? So different things work for different people, but I think the workload management isn't just how many pitches per inning, how many pitches per outing, or how many innings per season, although those are all incredibly important. I think it's also like, what do you do? What do your downtimes look like? What is your ramp up, your length of ramp up? On the college side, it's even harder because you don't have a perfect schedule, right? You go through fall ball, you take a bit of a rest, you take your finals, you go home for a few weeks, and then you're back on campus. You got to make the rotation or make, the top 10 pitchers on the coach's eyes. And then by February, you're pitching again, and then you're playing summer ball, and it keeps going. So I think it's, what do you do when you're not playing baseball in order to prepare the body to be able to deal with those stresses? I think that's critically important. I think that's the part that's more misunderstood. I think we're doing pretty good with understanding pitch counts. I think, that information is out there. Pitch Smart is out there. There's a lot of things that are out there. Whether they're followed or not are two different things, but I think the industry is doing a pretty good job with that stuff. I just think the ramp ups are really quick, and I think that's where the mistakes. I think that happens on rehab assignments for professional players. I think that happens on these small little micro breaks that college athletes have, and high school kids. If you're the best pitcher in high school, you're pitching a lot because that gives your team the best chance to win. So yeah, it matters, but I think in certain cases, workload management can be, if you're picking the over or you're picking the under. Sometimes it's too little, sometimes it's too much, right? So
now you mentioned like what you're doing in between. Is that getting in the weight room? Is that mobility programs? Is that working on things that are going to help to control lower body movement?
Yeah.
What are you finding with a lot of these young kids that are coming up?
It really depends on the individual evaluation when they first come in, right? So what are their needs? But I think to generalize, like if you're a youth athlete, like a young athlete, like under the age of 15, I think it's more times than not, it's not going to be mobility. It's going to be strength. Although we're seeing a ton of mobility issues with these, with the younger kids with technology and, more sedentary activities and things like that. For the most part, you got to get strong. You got to put body weight on. You got to get strong, or else you're going to get injured. I can't say that I don't care about movement proficiency when you're 12 years old, but more importantly, like I want you to love to move. Like I want you to be excited to exercise and learn the fundamentals that are going to be with you, not just for the rest of your playing days, but for the rest of your life. So I think that's critical. And then you get to 16, 17, 18, the ball's coming out of your hand a little bit harder. You're developing in a different way skeletally, right? So now mobility might become an issue. And certainly the way in which we're moving, now that you can create enough force to hurt yourself, the quality of movement is a big, big deal, right? And then we get through college and into the younger part of our professional life. And it's kind of all of the above: movement competency, mobility, strength recovery. The blend of all of those things is important. And then the older athlete, more times than not, it's mobility, right? The strength is there. The man's strength is there. Whether you move the needle by 5% on a deadlift at the time that you're 32 years old is not going to change anything. At that point, all of these are about it's only two things. How do you stay healthy, and how do you perform at your highest ability level? And I think that changes as we age. So I think that part's important. And I think it changes with the individual evaluation, our injury histories, reasons why we got hurt in the first place. I think all those things come into play.
In the same vein, you were talking about recovery, manual therapy, and the need for it. So how about some of the techniques like cupping, Graston, blood flow restriction, shockwave? Yep. How is that incorporated into an athlete's performance and recovery?
Yeah, so I think if it's somebody who hasn't had access to any of that before, then I think it's a matter of trying different things and seeing what gives you the best result. I don't know for sure that one is more important than the other. I mean, I prefer to use my hands over everything, although we do cup and we do needle and we do Graston and we do BFR, we do the newbie, we do all these different things. I think when you get an older athlete who's had all of those things already done to them, they will come in and be very clear with what they like and what they don't like. There are guys that say, I will not have a needle put into my body ever again because I had a bad experience, or I will never let somebody grasp me because I've had a bad experience. And oftentimes, guys, it's not the modality, it's the carpenter, it's the person who did the activity, where they turn a blind eye towards it and they say, no more for me for that. So I think it depends on the presentation. If somebody's very compressed and bound down, then maybe a little cupping to kind of open things up a little bit is a good idea. But we do a lot of those things in moderation, only because I think sometimes we get too aggressive with the manual therapy approaches, and we cause more harm than good. We cause more inflammation and things like that. So I guess to answer you, I think it's athlete specific. If they've never been exposed to any of them, then you try a few different ones as indicated. And if they have, a lot of times you either go with what they're comfortable with, mentally and physically, or you say, hey, maybe you got a bad experience there. I really think this will help you, and here's why. And this is who it's helped in the past, and kind of go from there. So again, unfortunately, a lot of these are individual. The answer is it depends on the athlete, but just trying to give you a little bit more texture to the answer than just that.
Yeah, I mean, I had a colleague I was talking to about this, and he said it's interesting because clinicians like everything that's shiny and new and it looks great. And he's like, don't forget what got us here, our two hands and what's between our ears. So yeah, I think for us as clinicians, that was well said. I think that we have to understand what the athlete needs and try to present to them the benefit of what is needed to get them where they need to be. So
yeah, I think it's that'll come out again when we start talking about any like technology and stuff like that. Is I think it's this like fine balance between the old school and the new school. This happened in baseball with the old scouts that could see with their eyes, and the new guys that just do data and analytics and algorithms and things like that. The truth is always generally in the middle.
So since you brushed technology,
yeah,
it was coming, right?
Yeah.
How do you think it's changing baseball rehab right now?
I don't think we're fully immersed in it as much as we will be. I think we are for sure, but I think we're doing great at collecting data. That was the first wave, is can we find these different things, whether it's the force plates or whether it's the mocap or whether it's the Proteus or the 1080 or whatever it may be. And we are very, very fortunate that we have access to all of these things. So I can speak to this. I think we started as being good at collecting data, and then we became pretty good at analyzing the data, although that took a little while, and it still is. Data analysis is a hard piece. But the golden, piece of this all is how do you take that data and implement positive change that isn't super laborious, that isn't super time consuming, that the athlete can get behind, and that can get real, like tangible results in a short period of time. So that takes expertise. And when all this stuff is new and, like you said, it's sort of the flavor of the month, it's really hard to call yourself an expert at something that you've only been using for 3 months. Mm-hmm. Right. So there are other people who have that area of expertise. And if our network is big enough, then we can tap into that and get in services and try to accelerate that. But I worry sometimes with people who only have one piece of that equipment, that, what is the saying? If all you have is a hammer, everything looks like a nail. So I think that becomes a little bit of a problem, but we're going there whether we like it or not. It's just a matter of, at the end of the day, the root of it all is, can we help the athlete? And can we keep them engaged and not just get caught up in, testing and data collection, and not actually getting tangible results to get them back on the field and keep them healthy. So that's, I think, the bridge that we're in right now.
If you had to choose one piece of technology for you as a clinician, is there something that you like or as a go-to that you would like to be able to provide the information to the athletes you're caring for?
I think measuring isometric strength right now is a big one. I think there's a lot of research to support how effective that is. So I think the different force plate or isometric measuring devices that are available, we use Hawken, which is a really good company that's worked well for us. Is Bode. There's other companies that are out there. I'd say that's probably where we're spending most of our time and getting the most tangible results, because it fits very cleanly with the rehab stuff that we do. So we do a lot of manual resistance and rhythmic stabilizations, and we go by feel, and we know when they're getting stronger by our feel. But it's hard to translate that when they go back to spring training, right? It's hard to translate that to a different clinician that has a different feel that may be better or worse or somewhere in the middle. But when you have numbers to support, a benchmark that, in a data set that allows you to say, hey, when you get to this number, you got a better chance of staying healthy when you start to swing the bat again, as an example. I think that goes a long way. We had a case this offseason with a big leaguer infielder who had a non-throwing shoulder recurrent subluxation and ended up having a capsular tightening and labral repair surgery. That it was like, okay, when are we strong enough to be able to dive back into the bag? That is the reason. Or when are we strong enough to take the second hand off the bat and let that lead arm fly in your follow through? Not just because it's been a certain number of weeks or months, or not just because, geez, you seem pretty good with everything else, so let's give it a shot. Instead, it was more like, okay, let's get these numbers. And then it becomes a competition. These guys want to compete, and they haven't been able to compete in a long time. So now it's like, okay, that's the number. Figure out how to get to that number, and then we'll talk about more fun things. So I think that part of it can be super engaging because it's gamified in a way, and that speaks a lot to athletes right now.
All right, I'm going to take a turn here.
Yep.
Because this just popped into my head. So I'm an upper extremity surgeon. I work for a Major League Baseball team. You have incredible experience with Major League Baseball players and baseball athletes of all levels for much, much longer than I've been practicing or working with baseball athletes. What should I, or someone in my position, upper extremity surgeon or a sports medicine doctor who wants to work with baseball athletes, what's something I should know that I probably don't know about the athletes, or that's commonly ignored or overlooked by some of the docs?
Yeah, I love this question because I think this type of opportunity to speak with you and these ways to be able to collaborate with surgeons was not a thing at all. Unless you were part of that same hospital system, it was not a thing. And the same held true with somebody in the private sector speaking with somebody in affiliated ball, whether it's a rehab coordinator or a head athletic trainer or a team doc or whatever it may be. So I think this is how, going back to your original question of how do you keep players healthy and advance the game, I think this is a great way to do it. So I appreciate the question. I think a huge part in the surgeon sort of relationships that I build is just an openness to collaborate. I mean, I think that's the number one thing. It's like, hey, give me an update how this guy's looking after X number of weeks, and it could be over text, it could be anywhere, but just having the ability to communicate and be responsive. Some of that, you talk about Dr. Andrews, I was blown away at his level the first time I saw a patient of his, and he was like, yeah, let's get on the phone and let's talk about it. And he has this tree of orthopedic surgeons underneath him, one of which I was exposed to that you guys probably know very well is Dr. Luke O from Mass General, who's now the team physician at Rothman in Orlando and the Orlando Magic. But he was trained under Dr. Andrews. So he was the guy that I became the closest with in Massachusetts because he called us back. And then we went to his office and did the surgical, the post-op stuff. We went into the surgeries with him. So I think the more we can find collaboration where the PTs can go out of their way to learn what y'all do and vice versa, I think that's number one, is just building rapport and a relationship of trust and recognizing, which I know you do, but a lot of docs don't. And a lot of PTs say, oh, this guy is this or that. It's just a matter of respecting areas of expertise and then knowing that we're better together than we are apart. I think that's number one. So, on the clinical side, I don't know about you personally, Dr. Roth, but I know in general, we're still seeing more stretching into internal rotation, sleeper stretches, things like that. Unfortunately, it's still out there. And I think that's not necessarily a good thing. And then I would say the positions of testing that I see when I go in with certain doctors into their rounds, they do a lot of like the traditional manual muscle testing, like with their arms by their side. I don't see as much as I'd like to see in like positions of either not just special tests, but positions that the athlete needs to get into throwing wise. So for example, if we're testing external rotation strength, are we doing it in the late cocking phase? Are we doing it in full external rotation at end range? So not just at 90 degrees or not just like by your side, but are we getting fully back here and testing them? Or are we getting way out in front at ball release to test? Because that's where guys hurt. They don't hurt in the middle. They hurt when they transition from ER to IR. or they hurt when they get out in front into full protraction and then IR and pronation. So if they have pain in their forearm and we're testing them with their elbow flexed at their side and we're just holding their hand and saying pull or twist in like a handshake position, that's something that we've had to strive to get better with, is being more specific of not, you can do we can all do our baseline testing and exam, but making it a little bit more specific to the areas that the athlete themselves actually get their pain in. That's huge. And then one of the hardest things to do in a clinical exam is doing it at a rate of velocity that matches because a lot of athletes don't get hurt when they have time to prepare, when they have time to stabilize, and when they do it in slow motion. A lot of times that doesn't provoke their symptoms. So we have our clinical special tests that we can determine with good specificity, elbow valgus stress tests or milking maneuvers or Neer's tests or, all these different things. But that helps us understand underlying structural pathology most of the time. It doesn't necessarily help us as much with movement impairments or things that we can fix if they're non-surgical. Without, obviously surgery is what it is. If it has to happen, then we need to find the best in the world to do it. But if it's not, then we need to know, like, what are the positions and what are the approaches that we can take to try to help these guys out. And I think the athletes appreciate that too. So
it's a great answer. I love it. That's awesome.
Appreciate it. Yeah.
We were very sad to see Dr. O leave and go to Florida, because I was on the phone with him probably once a week or email with a lot of our upper extremity athletes that we would send over there.
He's the best.
And he was great because I was introduced to him by Dr. Thomas Gill, who is one of my biggest mentors, and I know Cam as well.
Amazing.
And I love how you talked about functional strength training or testing, because I talk to therapists all the time and athletic trainers and ask them, are you testing to the full functional range of motion? And a lot of them kind of look at you like you're crazy. And I'm like, well, where are they having the pain? Where are they having the deficit? Yeah. And to me, it's just, I feel like you're doing a disservice to the athlete if you're not testing through that range to pick up where their deficit is. And you don't need to have evolved, isometric testing, handheld. You can do it with your, objective exam in the clinic. And we have a Kaiser machine at Weston, and we can use that to be able to test.
We work directly with our physical therapists and occupational therapists. They're in the same office as we are. Yeah. So we can actually just walk across the hall and meet with the patient, so we can have a sort of like a 3-person discussion between the surgeon, the therapist, and the patient. So that's incredibly helpful. And of course, I agree with the collaboration. I mean, that's the key. And Dr. Andrews is a mentor, I think, to all of us. And the fact that he's so responsive is something I emulate for sure and try to do that in my practice. But he was incredibly responsive to us and incredibly forthright and open about his practice and involving the family and the athlete's decision and being upfront with the athlete. And as you've seen, I think it benefits the athlete long term.
Yeah. It's a lost art. And that idea of like treating the patient is, everybody says they do it, but it doesn't happen all that much. Treating the patient as a whole and not just a body part or what have you. So, it's our job to make sure that we pass the torch on that, because we've had, this generation of physicians and clinicians that have done this, and we just can't get too busy to not do that. I think that's the most important thing that we can do is empathize. Even though we've seen it 1,000 times, it's their first time, and it's the most important part of their life at that moment. So we have to be respectful of that.
So being, I'll ask the question of being a high school athletic trainer working with youth athletes, because Cam was talking about professional athletes. Yeah. If you were speaking to a young athletic trainer coming out of school for the first time, what's the one piece of advice you would give them regarding arm health?
I would say the thing that helped catapult me, my career, is understanding the role of the scapula and what that means for a throwing athlete. So I had the privilege of learning under, probably one of my biggest mentors was Dr. Shirley Sarman down in St. Louis, who is sort of the godmother of physical therapy. And her whole thing is, how you move is how everything, and everybody now is like a movement specialist or has some sort of certification or what have you. But if you can, as a young athletic trainer, look at an athlete's an athlete move from the back and understand, the rhythm of what the scapula is supposed to be doing, and the dysfunction or the dyskinesis or whatever we want to call it that occurs in 95% of these athletes, and making sure that they understand that it's not just can you bench press or can you row or can you do a lat pull down or can you do a push up. It's when you do it, how is it happening, right? Mm-hmm. Because generally speaking, a lot of these kids are working hard, and they're being given good advice, and they're going to grind and grind and grind. But are you getting better at getting better? Or are you getting better at getting worse? So I would say the biggest thing that I would pay attention to isn't so much the amount of weight or the volume. It's more about what is actually, the goal of the particular exercise that you're doing, and are you getting that outcome? So I think before a youth athlete can put weight on the bar, put weight in their hand, they got to understand how to move. And a lot of people think that might be boring or you can't gain their attention or what have you. But if you can create context around the movement, this is the one thing that I would say that catapulted us quite a bit. If you can take context around the movement and say, okay, I'm going to have you lie on a table and do a trap raise, which is boring as can be for a 13-year-old kid. And then you can say in your delivery or in your swing, this is the pattern that you need to be able to do to hit the ball farther or to be more consistent in the zone or whatever it may be. If you can relate a boring exercise to an exciting activity for a kid, they'll do that exercise all day long. But if you just give them a bunch of boring exercises and say, here's your throwers 10, pull on this band and lay on the table and do 3 sets of 20 and good luck to you. There's no way. I wouldn't do it. I wouldn't care to do it. So I think understanding the role of scapula and then creating context for every exercise that you give them to make it a little bit more engaging and more exciting rather than just counting reps. I think those are two huge things that I would pay attention to.
Well, how important is thoracic mobility? Let me ask you that, because we talk about scapula, right?
Yeah.
Where does thoracic mobility fall into that?
Yeah, so I think what we always tend to say is the scapula delivers the arm. Like if we're just using the throwing motion, the scapula delivers the arm and the thorax delivers the scapula. So if the T-spine doesn't move, then the scapula doesn't, or it's not in the correct position, whether that's through breathing mechanics, whether that's through posture, whether it's through somebody who's hyperkyphotic or who is, a stiff militaristic looking T-spine. You have to identify that. And then you have to understand that the thorax determines how an athlete will look when they pitch. Are they going to be an upright thrower and have that kind of lasso finish, or are they going to have sort of that inverted, C, that like the Max Scherzer finish where you get a lot of flexion? And if they have the capacity, if they have a flexible T-spine, then they have the capacity to iterate. They have the capacity to make adjustments in the way that they throw. If they do not, if you try to have someone who has a stiff thoracic spine and you ask them to change the way they do something, I don't think they're going to have a lot of success. And I think you're going to increase their risk of injury. So I think thoracic mobility is important, not just in the rotational plane or the transverse plane, but very much in the sagittal plane as well, because there is a huge moment where we have to be able to extend at a point in our delivery, and then we have to be able to flex in another part of our delivery. So if we're just talking about pitching, it's critical. And obviously in a batter with all these oblique injuries that we're seeing, if you can't separate and have strength when your pelvis is going in one direction and your T-spine is going in the other direction, you're cooked, especially with the velocity that's out there and the number of swings that these guys are taking. That is critically important. So I guess to go back to that other question about, what do we want other people to pay attention to and look at? If we're testing core strength as an example, and we think that's a weakness as a precursor to an oblique injury, and we're not looking at T-spine and hip mobility, we're not looking at their ability to stabilize at the end ranges when the pelvis and T-spine are going in opposite directions, and all we're doing is laying down and having them do a dead bug or having them do like a lower abdominal test, that's not bad to do that test. It's critically important to do that test, but there has to be a battery of tests in multiple planes of motion, standing, not laying down, that we're able to do to identify like, hey, show me exactly in your swing, precisely the moment in your swing when you get your pain in your oblique. And then they show us and you're like, oh, okay, that makes sense. But we can't see that if we just lay them on the table and do a Thomas test and an Ober's test and test their lower abdominal strength. We cannot tell the difference. We're not making them better.
That was fantastic.
Yeah.
I mean, having, I think, adolescent kids, and you just have 2 college baseball players.
Yeah.
It's, we see the young athlete every day and they don't want to be upright because they're always looking at their phone or they're over a desk learning. And again, trying to identify the reasons why they're coming in to see you, but what are things that are causing this dysfunction that they're having. But again, understanding the scapula, understanding the T-spine, and making sure that you're doing the right things for them to make sure they're successful is key.
Yeah, I could speak to that a little bit more. Perhaps is just because they have bad posture, they're kyphotic when they walk in and sit in your office, or they're always over a device. It doesn't mean that they're not flexible. There's a difference between being in a bad position and being super stiff, and being in a bad position and being flexible. Like flexible meaning they can do an overhead, like a split stance overhead thoracic extension. If they can do that, then you don't need to mobilize them into extension. They're capable of extending. Therefore, they don't need to be mobilized to get there. They just need to do it more often. So our training programs and our recommendations, it can't be, hey, you're sitting like a monkey, you got to get the device out of your hand. Like, good luck. Like, if you're an old guy doing that, you're wasting your time. Like, you're not going to win that battle. But if you say, hey, you're not throwing hard like you want to be because you can't extend your spine because you're always flexed, and you can do it. Let's just do these exercises to get you in that position more often. And then, have these micro breaks from their gaming or whatever it may be. I mean, we think it's just kids. We have big leaguers that they train their butt off for 4 hours a day in the gym, and then they go home and they game till 3 a.m, like every night. It's not just like one dude. Like, that's a thing. So, and those guys they're stiff. They don't have the privilege of youth. They're not a 13-year-old kid that can twist themselves into a pretzel. These are guys now that if they get stuck in that position, they're going to come in hunched over with back pain the next day, and yet they still do it. So it's not just the kids, but again, it comes down to context. Like, tell them if they do this, don't lie. Tell them if they do this, they'll become better baseball players. That's a hell of a lot better than saying, the old guy that looks like me really doesn't want you on your phone anymore. Like, that's not gonna sell.
What role does FMS play in this evaluation process? Is this something that you guys would use and identify or use in clinic for young clinicians to understand where the deficits are?
I mean, for us, our evaluation stuff is constantly evolving, right? We have the privilege of, I know Eric was on your podcast and he went through his evaluation stuff. I think every off season, it adjusts and improves a little bit, where we take things out that aren't as important and we add things that we think are now more important than what we once thought. So I think the FMS is a great foundation for being a screening tool. I think it's an amazing way to hit 25 athletes in an hour, right? If you can train an aide or an assistant to be able to look at some of that stuff. And I'd rather an expert clinician do it. But if you've got a big group that you got to pump in and out, if I'm a college, a college athletic trainer, that, my God, I have so much respect for that role, because you got an hour in the weight room and then boom, the next team comes in. It's like, it's crazy. High school is the same. Like, it's crazy. So I'm using a screening tool that may not be perfect, may not encapsulate everything, but if we're using the 80-20 rule, like, if it gets us 80% of the information and 20% of the time, like, I'm not going to say that's a terrible thing. Like, if that's the only thing you're using in a super niche, like hyper specialized type of population, you probably need to evolve a little bit more than that. But if you're just getting going, like, there's good research to back that it at least puts you in the right ballpark. It puts you in the right classroom. Right. So I don't say it's a bad thing. And there's progressions to that. If that's the path you want to take, you can go SFMA and you can do some of that, continuing education along that path. But at the end of the day, it's having a system, being able to be efficient and being able to translate it to the athletes so they can understand when they leave after the first day, like, hey, this guy knows what he's doing, or this girl knows what she's doing. And they're going to be the ones that help me. Like, I mean, I don't think there's any one way to do it. We'd be crazy to think there's only one way to do it.
Lightning round. Quick questions, quick answers.
All right.
These are good. Eric, you look horrified that we just said lightning round, but
no, I'm ready, man. I love this stuff. It's great.
What's the most impressive comeback you've seen from an injury?
It was well known, and he spoke about it in the media. So I had the ability, I had the privilege to work on Justin Verlander's Tommy John rehab at age 39, and he came back the next year and won the Cy Young. Nice. So I thought that was pretty cool. Oldest guy to ever win the Cy Young after Tommy John rehab. I think maybe one of the few to ever do it, but he did it at age 39. And just what was impressive isn't like the glamour of, working with a guy like that, but just how much he taught me and the amount of work that man put into that. The amount of this is the lightning round.
No, but this is a great answer. You keep
the
it
amount
going.
of consistency that he put in at that age when he had nothing to gain except his legacy and just to see if he could do it. That changed me for sure. So it was cool.
Most underrated exercise for throwers?
I'd say like an end range rotator cuff, external rotation strengthening exercise, isometric at the absolute end range of what they have available.
Past 90. Like
way past 90.
Yep.
Do not use bands and stop at 90 degrees. That's a waste of time.
It.
Yep.
Love it.
Yep.
Most overrated recovery tool.
I might take some heat for this, but I would say foam roller, massage ball, massage gun, anything that, if you're a clinician getting paid to work on somebody and we're using a device or something external that they could do in their bedroom, I would say we should use our hands and get a little dirty. But even so, I'm not totally against. I think there's some value to those things, but if it's a replacement for manual therapy, I think it's lazy. So
I tend to teach athletes how to use it when on the road.
Yeah, it's great.
They take it with them, especially track athletes, because they'll go to meets and they're alone and no one's helping them. So I'm like, here, this is how we use this. If you
better
need
than nothing, but if we're
exactly,
yeah.
I'm looking at the 2 foam rollers I have here lying on the ground next to me in preparation for my training.
They're not terrible. They've gained mass appeal, and everybody walks into the gym, and it's the first thing that they do. The compliance is through the roof. With foam rollers. So if we could get people to do that with
your warm up.
Right. But we can't go to bed on time or we can't eat well, but we can get on that damn foam roller every single day. So,
but 90% of the people are using it incorrectly. So, I mean,
So I don't know. It's like, again, it's same. I said the same thing. I think they're fine. They're not a replacement though. But when you got nothing else, I think it's good. So
one thing you wish every coach understood about arm care.
That it's a bad name, that arm care is a bad name because you don't pitch with just your arm. So if whenever everybody says, I got to do my arm care, I cringe because if you're not getting the rest of your body ready to throw, you're generally wasting your time. So I would call it something different.
Best lower body exercise for pitchers?
I'd say like a single leg RDL.
Love it.
Yeah, for a lot of different reasons. Yeah. That's what I would go with. I mean, there's a million.
Balance,
but if
stabilization, and strength, pure strength. Yeah.
Single leg. You don't pitch on 2 feet, so you got to train them on one leg. Or
I tell runners the same thing. I'm like, you don't run on. Yeah, you gotta move, man. You're on one leg all the time.
What's next for baseball rehab and performance?
AI. Yeah. I mean, I think that's the easy answer. So technology for sure. Recovery is a massive game changer. The people who recover the best are the people that perform the best. Look at Kobe, LeBron, look at all the greats. But yeah, I mean, we'd be silly to be behind on the AI trend. So it's a matter of trying to figure that out and embrace it and not be scared of it. Not that any of us are experts in it right now, but I think it's coming. So we got to get up to speed with it.
One word to describe baseball rehabilitation.
I'll just say challenging. Like, I think it's a wonderful challenge that we're all blessed, if we're in this field, to be able to undertake every day. And I think if we can continue to work, we can maybe put a dent in this thing, but we're all trying like hell to be able to do that. So.
All right. This is not a lightning round, but we talked to Curt Schilling and asked him the same question.
Yeah.
What do you think of Ohtani?
Just generally?
Yeah, I mean, have you ever worked with him? Have you ever seen a specimen like him?
I have not worked with him. I think he is. I think he's a unicorn. I think he's like Wembanyama in the NBA. Like, I don't think there is or was or will be another person. I think there'll be people that pitch and hit. There are people that are in that realm right now. But I mean, to do it, he's arguably the best pitcher this season right now with his statistics. He has like a 0.7 ERA. Like and he's not hitting on days that he pitches anymore. So he's focusing only on pitching for that one day, and now he's the best on the planet. So, and if he focused only on base stealing, he did that 2 years ago, he was 50-50. Like, come on, he's the best player at anything that he does. in any round. He could be the fastest, the strongest. He could win the batting title. He could win the Cy Young. Like, it's crazy. Like, it is the craziest thing I've ever seen.
That's exactly what Schilling said.
Yeah, he said that's like verbatim. He was like, best hitter every day he hits, best pitcher every day he pitches.
I mean, to be a Major League Baseball player and see that, and you work every day for your whole life, and then this guy rolls in, it's like you're playing two different sports. Like, it's crazy. But we're lucky to be able to watch him in real time. It's pretty cool.
It's cool.
My final question.
Yes, sir.
Red Sox or Yankees?
I mean, Red Sox because it's in my blood, and I'm from around here, and I've worked with quite a few of those guys. But boy, they're making it really hard to root for them with the way that they're managing their players and their whole system. So they're making it hard. Yeah, Eric and the Yankees. Obviously, I got a soft spot for that. I'd love to see them get a World Series championship with him on board. But, if I had to pick, it's in my blood. My grandparents would get mad at me if I said anything different. So they're not around anymore. But if they were, they would get upset. So
awesome, Eric. Thanks again. We appreciate you coming on here tonight. Hopefully this information is going to help a lot of people, especially youth athletes, and then up and coming, hopefully aspiring collegiate baseball players and above. So we appreciate your time.
Appreciate you guys for having me on. I love what you guys are doing. Hopefully we can stay in touch.
Thanks, man. That's awesome.
Right. Take care, guys.
Thanks for listening to Behind the Sports Medicine Podcast. Follow us on social media and check out our website.
The information shared on this podcast is for educational and informational purposes only and is not intended as medical advice. Please consult a licensed healthcare provider for guidance related to your specific situation. We'll see you next week.